always wonderful to come to Seattle. There's so many distinguished investigators here who know a great deal about what I'm going to talk about this morning. And so I'll be interested to hear the input of the audience, and so I'm going to try to stop 20 minutes after the hour so that I can get your input. So as Andy mentioned, I am a hematologist, and I have had a long-standing interest in developing novel genetic therapies for hematologic diseases, particularly hemophilia. So I'm going to start this talk by the requisite slide on the coagulation cascade, which is one of the critical homeostatic mechanisms of the body and ensures that a nick in the vascular tree does not result in exsanguination. And this series of controlled proteolytic reactions eventually culminates in the production of thrombin, which has protein effects in coagulation, not only through activating platelets, but also cleaving fibrinogen, which is a soluble protein, into a form that can undergo polymerization and form the structural basis of the clot. So by convention, all of the proteins involved in coagulation are designated by Roman numerals, and a deficiency of any of these can result in a bleeding diathesis. But because factor VIII and factor IX are encoded on the X chromosome, these are by far the most prevalent because hemizygous males are affected. So deficiencies of factor VIII are called hemophilia A, and of factor IX, hemophilia B. And despite the fact that the genes were cloned and the crystal structure for factor IX is available, despite a very exquisite molecular understanding of the proteins involved, we actually don't know why it is that the primary morbidity of the disease is actually bleeding into the joints and soft tissues. But people can also bleed into other critical closed spaces like the intracranial space, where the bleed can be rapidly fatal. The worldwide prevalence of the disease is about the same everywhere. And this is a very important fact for gene therapy, and that is that people with less than 1% normal circulating levels of factor VIII or factor IX are severely affected. And they're the ones who are at risk for spontaneous bleeds that can actually be life-threatening or fatal. But even a modest increase in the circulating level in the range of 1 to 5% greatly decreases the morbidity of the disease and the risk of fatal bleeding. So that's really our target in gene therapy. If we could manage to get to that sort of level, we would greatly ameliorate the symptoms. And people with levels above 5% can actually be undiagnosed during childhood. That's how mildly they can be affected. So let me just say that currently we treat hemophilia by doing intravenous infusions of either recombinant or plasma-derived clotting factor concentrates. And typically when children are little, they get these infusions done in the clinic or the hospital, and then as they get older, they and their parents learn to do the infusions. The earlier plasma-derived clotting factor concentrates ended up being contaminated with viral blood-borne viruses, including HIV and HCV, and complications of those infections are now the major causes of death among the hemophilia patient cohort in the Western world. But the current heat-treated plasma-derived concentrates and recombinant proteins are free of these complications. And so for those people, the major remaining complications of protein infusion are just that you can develop inhibitory antibodies to factor VIII or factor IX, depending on your level of tolerance to the protein and the cost of the product, which for an adult with severe disease who treats himself in about the mid-range of treatment patterns costs about $100,000 a year. And a consequence of that is that your life expectancy in hemophilia depends on whether you live in a relatively wealthy country with a good gross national product or a poorer country. And this gives relative numbers of patients under the age of 13 and above the age of 19 as a function of the country's GNP. And you can see that in poor countries, the disease is still fatal in childhood and adolescence, and there aren't many adults with hemophilia. So that's one of the problems that has driven a search to find some other type of treatment that would result, instead of these peaks and troughs in the levels that you have as a result of protein infusion therapy, some constant level of factor that would be enough to prevent most bleeds rather than trying to treat them after they've occurred. So if the objective of what you're doing in gene transfer is to get long-term expression, there are essentially two types of ways to do that. One is that you can use an integrating vector and introduce it into a stem cell so that then all the daughter cells will carry the donated DNA, and you'll get long-term expression on that basis. And the other general strategy is to try to transduce a long-lived post-mitotic cell type, such as cells in the central nervous system or cardiac muscle or skeletal muscle or something, very long-lived. And then you don't necessarily need integration as long as the donated DNA can persist in the transduced cell. And that's really the strategy that we've been interested in hemophilia. So to do that, we've been working with recombinant adeno-associated viral vectors for a number of years now. And these are probably one of the simplest viral vectors that have been used in gene transfer approaches. It's engineered from a small wild-type virus that is actually a dependovirus, so it's naturally replication defective, can't replicate except in the presence of a helper virus, such as adenovirus. Many of us are infected with AAV, wild-type AAV during childhood, but it's not associated with any known illnesses, so it's naturally non-pathogenic. To make a recombinant vector out of it, the viral coding sequences are completely deleted, so the replication genes and the genes encoding the capsid are deleted and replaced with the transgene of interest. It turns out that AAV has a natural tropism for certain long-lived post-mitotic cell types, including skeletal and cardiac muscle, liver, and cells in the central nervous system. And it further turns out that the DNA persists predominantly in an episomal, non-integrated form. So the issues that attend the risk of integrating vectors are less of a problem in this setting. And finally, in the mid-1990s, two separate groups demonstrated that recombinant AAV vectors could drive long-term expression of a transgene in an immunocompetent animal. So it was really on the basis of that that we became interested in using this in hemophilia. So just to say a little bit more about recombinant AAV vectors, the capsid, so the final vector product consists of the vector capsid encasing or enclosing the DNA of interest. And this is the rough composition of a vector, 74% vector capsid, 26% DNA. And this icosahedral virion is composed primarily of viral protein 3, VP3, 50 molecules of VP3, and 5 each of VP1 and VP2. So that's the composition of the vector capsid. And now I'll just say one word about the production method that we use. There are a number of different ways to produce AAV, and the method that we use in our center is diagrammed here, and it's a widely used method. So it's triple transfection of 293 cells with a plasmid expressing the therapeutic gene of interest cloned between the two viral inverted terminal repeats. A second plasmid that supplies the replication and capsid genes in trans so that you can actually make the recombinant virion. And then a third plasmid that encodes the necessary helper genes from an adenovirus so that you can get replication. So the 48 hours after transfection, the cells are lysed and the product is harvested. And this diagram illustrates that most of what comes out of that is in fact empty capsid. And a relative minority of the particles actually have the DNA of interest packaged. So there are many different purification and preparation methods, but we actually do remove the empty capsid, which is shown here on this density gradient, from our final product. So our final product includes full capsid, and this material is removed, which we think is important for two reasons. One is that, as I hope you'll agree after my talk, this empty capsid is not immunologically inert. So that's one reason to remove it. And the second reason is just that, since vector uptake is receptor mediated, if you flood the receptors with these guys, that's going to put these guys, get fewer of those into the cell. So, all right, I think I've said enough about vector, and what I want to say is that through the years, we pursued a paradigm that looks basically like this, and we've actually examined a number of vectors, not just AAV, but we investigate things in tissue culture and small animal models. If that looks good, we move into large animal models. And if the safety and efficacy data then support it, we've moved into human subjects. And what I can say is that our data here look good. Our data in hemophilic dogs look good. And the question is, can we make this step safely and efficaciously? And here's the one-slide review of my whole talk right now. The human studies have shown this. If we put AAV into skeletal muscle, we can show long-term expression in humans, but the levels aren't high enough to make the disease better. If we go into the liver, we can achieve therapeutic levels, but instead of the long-term expression that we observe in dogs, we observe relatively short-term expression in humans. So we need to solve one of those two problems. And then we'd have a new platform for treating hemophilia. So now what I'm going to do is show you sort of where we are on these problems. And before I start, I just want to mention one other thing. I believe that an important result of the work in clinical gene transfer that has gone on across many platforms and many diseases over the last 15 years has been the development of what I believe is a fairly complete problem list of the things that can go wrong in gene therapy. And this is that list. So, the gene can be silenced. You can experience genotoxicity from an integration event, and that's, of course, typified by the development of leukemia in children with X-linked SCID who are treated with a retroviral vector. You can have a phenotoxicity, which results from either overexpression or ectopic expression of the donated DNA. You can have unwanted immune responses to either the vector or the transgene product. People worried a lot at the beginning about whether there would be horizontal transmission of vector, whether patients would shed it, and then they would infect, the guy in the next bed or their household contacts or whatever. I think this is less of a concern now. And then the risk that the vector, from the point where you introduce it, would make its way to the germ cells and be transmitted inadvertently to future generations. So this is the problem list, and I think, it's actually good when you get to a point where you have a complete problem list, and I think this is probably reasonably complete. So these are the problems we need to solve, and I think that if you survey the literature in gene therapy, what you see is that for each combination of vector, transgene, and target tissue, one or two of these problems will predominate, so you won't have to deal with all of them, but you'll probably deal with one or two of them most prominently. And for what I'm going to tell you about, which is in vivo gene transfer with a viral vector, I would have to say for us the major problems have been centered around the immune response. So let me just say by way of background, because I'm not going to show you all these data in mice and dogs, but using hemophilia B mice and hemophilia B dogs, we developed a lot of background information preclinical data that showed that we can introduce a recombinant AAV vector either into skeletal muscle or into the liver and get long-term cure in small and large animal models. I want to say we began all of our work with factor 9 because it is smaller than factor 8 and it is easily accommodated in an AAV vector, which does have a size limitation. But we have managed to put a truncated version of factor 8 into the same vector, so I think if we can solve factor 9, we should be well on our way to factor 8. This slide shows preclinical data in the hemophilia B dog model using a recombinant AAV vector expressing canine factor 9. And what it shows you here, these are data where we use muscle as the target, and these in green are data where we use liver as the target. You can see that there is a very decided dose advantage in favor of liver, that in skeletal muscle we have to use a 10-fold higher dose, 10 to the 13th vector genomes per kilogram, to get circulating levels of 1 to 2% in a dog, and you can use a lower dose and get better levels when you go into the liver. But when we got ready to start our first human studies, there was no experience giving AAV into either muscle or liver. And our own impression was that it was probably smarter to start with a peripheral tissue than to go immediately into the liver, since there was no human experience. And so that's what we did. And in the first trials that we did for hemophilia B in the muscle, people were just injected in direct intramuscular injection. Our target was to reach that dose that had given 1 to 2% in dogs, so we were trying to give 10 to the 13th vector genomes per kilogram. And what we found was all the subjects tolerated the vector injections. We went up to 2 times 10 to the 12th vector genomes per kilogram. There were no local or systemic side effects, no inhibitor formation, no evidence of vector sequences in the semen. These are muscle biopsies done on the subjects, and we did these as early as 2 months and as late as 3.5 years after vector injection, and they look pretty much the same whenever you do them. So this is an immunofluorescence stain for factor IX, and you can see at the injected site that factor IX is being expressed. And if you do a southern blot on DNA extracted from this muscle biopsy, you can actually locate the donated factor IX sequence here as a 4.5 kb sequence. So all that looked good, but we were not getting circulating levels greater than 1%. Now, you see here that we were still 5-fold short of the target dose that we knew from the dog work. So why didn't we just keep going? Well, the fact is that at this dose, we were already up to 100 injections. So it becomes like a bad acupuncture procedure to think about going higher than that. And there were some reasons that we were concerned about going higher than that. I mean, we knew from studies in tissue culture of muscle that, factor IX is a highly post-translationally modified molecule, and you can saturate the ability of skeletal muscle to accurately and efficiently carry out all those post-translational modifications. So if you want to express more factor IX, you have to access more muscle. That's why we had to inject more and more sites. You can't do it by just injecting more and more AAV at the same site. So there's an efficacy reason. In a series of studies in hemophilic dogs, we had shown that as you gradually increase the dose of vector delivered to a single site, you seem to increase the risk of forming antibodies to factor IX. So there was a safety reason not to keep dose escalating. And finally, I think this is obvious. If vector uptake is receptor mediated, you can't just put more and more vector into one site. You got to access more muscle. So we actually started a series of experiments with a colleague of ours at Penn, Hansel Stedman, who's interested in gene delivery to skeletal muscle for muscular dystrophy. And so the problem in muscular dystrophy, of course, is that you have to access vast regions of skeletal muscle because you really need to correct all the cells. So Hansel had begun working with a vascular delivery procedure, and what he had demonstrated was that in order to get AAV, which has a diameter of around 20 nanometers, across the vascular endothelial barrier, you had to somehow increase capillary permeability, which you could do either chemically using a drug that increases permeability or mechanically by just using very high hydrostatic pressures. And so in the first iteration of the work that we did with Hansel, we used a procedure called isolated limb perfusion, which is actually used to deliver high doses of chemotherapy to a single limb, so for a sarcoma or a melanoma or something like that. And what they do in this procedure to deliver chemotherapy is you do a cut down in the groin, you isolate the femoral artery and vein, and you infuse the chemotherapy after sort of tying off the circulation for a short period of time, and then you flush it all out, and that way you avoid systemic exposure to these high doses of chemo. So Hansel basically just adapted that for vector delivery by, again, you isolate the femoral artery and vein, you put ligatures around them, you take the vector, you mix it with histamine to give a vascular leak, and then you get great transduction. You let it dwell for about 10 or 15 minutes. You flush it out with saline, and then reestablish the systemic circulation. And so we actually did that with our AAV factor IX vector, and this is meant to, we did it in dogs. We have not done this in people. And this is meant to illustrate the difference between direct intramuscular injection, where if you go back in and biopsy, you see a positive response right where you injected the vector, whereas with the isolated limb perfusion procedure, you can biopsy anywhere in the distribution of the artery, and you can see factor IX being expressed. So When we did this in hemophilic dogs, we were able to show that we got very long-term expression, greater than 3 years and counting, that we could get excellent circulating levels, now in the range of 4 to 14%, with a dose of vector that by direct intramuscular injection had only given us about 1 to 2% circulating levels of factor IX. And that, as you would predict from these kinds of levels, it reduced the bleeds in the hemophilic dogs from an expected number of 34 over the period of 72 months of observation to 4. So you got very good prevention of bleeding in the animals. However, there were 2 reasons that this was going to be difficult to translate into humans. One is that, in data that I don't have time to show you, we also showed that when we delivered these kinds of doses, we had to use short-term immunosuppression with cyclophosphamide, otherwise we got inhibitors to factor IX. So we had to do that for 6 weeks, and then you could stop it and you didn't get inhibitors after that. And secondly, this whole thing requires a surgical procedure and a vascular surgeon, and histamine is not a drug licensed for human use. So, all those things are going to make it hard to do in a person. So Hansel actually went on to develop another procedure that did not require histamine or a surgical procedure. And this involved simply a cut down on the saphenous vein, and the vector was administered in a high volume of fluid under pressure. So you mix up the vector in a fairly large volume of saline, put a blood pressure cuff around the bag and pump it up to 300, and you just push it in rapidly through the saphenous vein against an obstruction caused by a tourniquet placed at the hip. And this tourniquet technology is very well developed for use in humans because the orthopedic surgeons use it all the time to conduct so-called bloodless procedures in orthopedics. But anyway, so you infuse the vector in a large volume of fluid against an obstruction. The leg swells up in a dog. The leg swells up. But you get great transduction. So actually, I'll just show you. I mean, this is a dog that was infused through a cut down in the saphenous vein. And then these are biopsies done at several weeks after that. This is with an AAV-LAC-Z vector, and you can see you get beautiful transduction across all of the musculature in the leg. So now you don't need a surgeon, right? Because even an internist can hit a saphenous vein. And you don't need histamine. So it's really just mechanical pressure. But we did find that we still needed the transient cyclophosphamide over a period of 6 weeks, once a week dosing, to prevent inhibitor formation in this procedure, as long as the animal was not tolerant to factor IX. So in other words, if you do this in a normal dog, you don't get antibodies to factor IX. If you do it in a hemophilic dog, you do. So, the question becomes, how do you move that into the clinic? Well, let me just tell you that, first of all, we get great levels of circulating factor IX with that procedure. This is the factor IX activity level in a dog that, again, this is a dose very close to what we've already delivered to humans using direct intramuscular injection. And, direct intramuscular injection gives you these kinds of circulating levels. This ALP procedure gives you these kinds of circulating levels of factor IX. So big difference in the factor IX circulating levels. So the question becomes, how are you going to move that safely into the clinic? So let me just summarize the muscle work we've done to date by saying that for us, skeletal muscle is an important target tissue. And the reason for that is that a large number of adults with hemophilia have non-trivial liver disease as a result of being infected with hepatitis viruses from the old concentrates. So we'd like to be able to use muscle as a target tissue. Direct intramuscular administration of an AAV vector into skeletal muscle was safe and gave long-lasting expression as judged by muscle biopsies, where you could still see factor IX being expressed as long as 3.5 years later. And the animal models accurately predicted many aspects of the human study. These are muscle biopsies of mice, dog, and humans injected with AAV factor IX, and you can see that they really look quite similar. These are immunofluorescent stains for factor IX. But in our first clinical study, our margin for translation That is, we were getting levels of 1 to 2% in dogs. I mean, that was awfully modest for translation to humans, and our delivery method was simply too cumbersome. And these intravascular delivery procedures seem to solve the problems of the cumbersome delivery. We can get much better levels in dogs now, and what we have to do is figure out how to do this safely in human subjects. And I'll tell you what my bias is in this, is that the ideal first situation for using this intravascular delivery procedure in skeletal muscle is the following. The muscle tissue is healthy, so that unfortunately is going to let out, in my opinion, the muscular dystrophy patients, because they don't have healthy skeletal muscle. They've got muscle loaded with inflammatory cells. And a situation where the host is fully tolerant to the transgene product. Okay, well that lets us out, right, because we're trying to put in factor IX, and our patients are not going to necessarily be fully tolerant to factor IX. So is there another potential solution? Well, I think that there is, and that is, remember that to generate thrombin, there are basically two ways to do this. You can come through the intrinsic pathway, which is where the missing factor IX is, or you can come through the extrinsic pathway. And we know from many years of experience using recombinant factor 7A that we can drive coagulation through the extrinsic system and achieve hemostasis that way. So I don't have time to tell you about all the data, but we've been slowly building a data set using an AAV vector expressing factor 7A. And it's really beautiful work, and I would urge you to read it, but I'm not going to have time to go through it. But we actually built a recombinant AAV vector that expresses factor 7 in an activated form. And we have shown now, I can't go through all this data, I don't have time. We've shown in both mice and dogs that we can get excellent hemostasis using 7A as the transgene product. And everybody with hemophilia is tolerant to 7A. So, sorry, this I'm just going to have to tell you to read about if you're interested. But, you know, that would be a situation where you'd have healthy skeletal muscle as the target tissue and a host that was fully tolerant to the transgene product 7A. So I think we're going to need a situation like that, like this, you know, to test this intravascular delivery procedure. But, I mean, what really happened in the clinical studies was that, you know, when it was pretty clear that we could not continue to move forward by direct intramuscular injection because it just wasn't feasible, we decided that, well, on the other hand, we had good safety data by intramuscular injection. So since we had a big dose advantage when liver was the target tissue, that we should move to liver. At the same time, we had been developing another data set that suggested that expression from an AAV vector in liver cells tends to promote tolerance to the transgene product. So that's good. That's important in hemophilia because, as I mentioned at the outset, one of the most worrisome potential complications of any new treatment method in hemophilia is that the recipient would develop an antibody to factor 8 or factor 9. So the ability to promote tolerance to the transgene product, factor 9, would be a welcome characteristic of any kind of gene transfer approach, and it was not something that was true in skeletal muscle. So, again, our preclinical data in hemophilic dogs had shown that you could inject vector on day 1 into the hepatic artery or the portal vein and get very long-lasting expression at levels that would clearly be therapeutic. These are 3 different dogs, but I mean, we've done this in many, many dogs, and that we could get expression. This is 140 weeks, but we followed these animals now for 7, 8, 9 years. They get very long-lasting expression. So the clinical study was aiming for this dose of 10 to the 12th vector genomes per kilogram. And so because it was the first use of AAV in the liver, we had to start at a relatively low dose. So this is a procedure that's done in the interventional radiology suite. The radiologists put a catheter in through the femoral artery, and they just thread it up, float it out into the hepatic artery, inject dye to make sure they're in the right place, and then they inject the vector. We had to start at this relatively low dose. Our prediction was that we should see efficacy either here or here. Remember, the dogs got 1 times 10 to the 12, so with levels of 6 to 8%. So what happened was the first 2 dose cohorts, in fact, were subtherapeutic. There were no complications, but there was no efficacy. But the first subject in the highest dose cohort is shown here. So his baseline was less than 1%. You can't measure factor levels in the first week because the patient's getting factor IX replacement to prophylax against bleeding from the femoral puncture site. But starting at 2 weeks after vector injection, he had pretty good levels, over 10%. And at 3 weeks, he had over 10%. At 4 weeks, he had over 10%. So, you know, things were looking pretty good here. But over the next 6 weeks, he did this. So his levels slowly began to decline, and by 12 weeks after vector injection, they were back down to his baseline. And that loss, or that, you know, gradually declining factor IX expression was accompanied by something that we also had never seen in an animal model, and that was after 3 weeks of normal liver function tests, the patient's transaminases started rising. So transaminases are a sign of liver injury. So they started rising at 4 weeks, they peaked at around 5 weeks, and then they slowly came all the way back down to normal with no medical intervention. So during this whole time, the patient felt well. None of his other lab studies were abnormal. We tried to work him up for some cause of these elevated liver function tests, and he didn't have any new evidence of hepatitis A or recrudescence of C or anything like that. So there was no apparent explanation from other causes that might make your LFTs go up. This patient was remarkable for having very low anti-AAV antibody titers at the outset. And the second patient who was done at this dose had higher anti-AAV antibody titers. We were suspicious that high antibody titers would block transduction when you go in through the hepatic artery, but we had no proof of that. And so we let this patient come onto the trial, but he never got much expression, and what little he had rapidly disappeared, and he never had any transaminitis, elevation of these liver enzymes. So, you know, here we learned that the neutralizing antibodies were going to have to be avoided, and also that they're protective against transduction. So that was very important for us, that dose cohort, because essentially it did, you know, several things. One, it identified what would be a therapeutic dose of vector in humans, and actually this was pretty accurately predicted by the work in the dogs. So that's an important observation if you want to do liver studies. This issue about the neutralizing antibodies through this route of administration I mentioned, but also we observed this phenomenon that we had never seen in animal models, and that was a loss of expression accompanied by a self-limited elevation of liver enzymes that started about 4 weeks after vector injection. So, you know, what we tried to do then was think about, well, how are humans different from all the animal models that we have worked it with? And, you know, obviously AAV, you know, humans are a natural host for AAV2, and so the question was, did they have some sort of memory response to AAV from their wild-type infection, probably during childhood, and was that what was, you know, altering the outcome? Or was it the fact that all of our preclinical work in animals had been done in animals that don't have hepatitis, that have normal livers, whereas most adults with severe hemophilia have been exposed to hepatitis C, so was that somehow the problem? You know, we tried to think about, why did we get this elevation in liver enzymes? Well, you know, I told you we worked the patient up for anything unrelated to gene transfer. He didn't seem to have it. We reasoned that if it were some sort of direct injury from our vector, it should have happened right after the vector went in, not 4 weeks later, and that the time course really suggested that it was some sort of immune-mediated response. And so here we're helped by the fact that this is a very simple vector. There are really only 2 types of antigens there. There are the antigens of the vector capsid. So this is a protein that comes in, is present transiently, and will eventually be degraded and cleared from the transduced cell because it's not encoded in the vector. And then we have factor IX protein antigen. So the vector, the DNA encodes factor IX, And it is conceivable that to these hemophilic recipients, the factor IX wild-type protein would look like a foreign protein, and that they might mount an immune response to that. So we thought, okay, well, we only have 2 antigens, so that's important, and we should be able to figure that out. And but here's what happened. So that subject was actually the one infused in October of 2002. And I'm going to show you that eventually we were able to do one more subject. But when after we got the data that I'm about to show you, the AV biotech company that had been making our vector for this trial said to us, well, Dr. Howe, we believe you when you say that you will solve this problem, but we do not believe you are going to solve it in a time frame that is meaningful to our investors. So we're going to get out of AAV and gene therapy, and so, we're going to transfer this IND to you, and best of luck. And so then we really had to make a decision, which was, do we want to keep doing this, or, So actually, very fortunately, we were able to convince the hospital that it would be a good investment of their resources to help us set up a facility to produce clinical grade vector at the hospital. And I'm happy that the hospital leadership actually is forward-thinking enough to think that cell and gene therapies are probably going to be important for pediatric diseases, and so they decided that they would support this. And so we eventually were able to reestablish the production facility in the hospital and recruit other key support, including regulatory support, to run these trials here. And so we were back in business, but we had a little, time to build this infrastructure. The other reason this was sort of a watershed event for us is the following. I mean, it became clear from what I'm going to show you that, we were going to have to tackle some human immunology if we were going to get through this. And that really wasn't what our lab did. But it also became clear to me that nobody was going to solve it for us if we didn't work on it. So we had to make the decision to do enough applied human immunology to get through this. So that's what I'm going to show you now. So, I mean, time is getting short. I'm trying to think how to cut this to the chase as quickly as possible. But let me just explain one background slide, and that is that basically, the goal of the immune system is to survey intact cells for pathogens or non-cell proteins. And it accomplishes this through MHC molecules, which have as their job binding proteins from the intracellular compartment and displaying those on the cell surface to circulating lymphocytes. So there are 2 MHC molecules, MHC class 1, which bind proteins that are being made in the endoplasmic reticulum, and class 2 molecules, which bind peptides derived from proteins in other compartments, including endosomes. Class 2 molecules present peptides to CD4 cells, which, when they recognize their cognate antigen, secrete cytokines that help to orchestrate the immune response. Class 1 molecules present to CD8 T cells, which, in addition to secreting cytokines, can also release cytolytic granules that can directly destroy the cell. So in the next subject that was identified, it was a subject, fortunately, with no previous history of exposure to viral hepatitis, low pretreatment antibodies to AAV, so we felt like this was going to be very informative. Unfortunately, the FDA forced us to use a dose that we'd already shown was subtherapeutic, but they have 51% of the vote, so that's what we had to do. And what you can see here is that the subject manifested a change in his liver function tests on a time course very similar to what we'd seen in subject E. So the total rise in LFTs was much lower than in the subject who got a 5-fold higher dose, but the kinetics were essentially the same. And in this subject, we were able to draw lymphocytes all the way through and test them for response to either factor IX or AAV capsid. And to do this, we used a screening assay called an ELISpot assay. So you basically stimulate the patient's peripheral blood mononuclear cells with peptides either from the AAV capsid or from factor IX and see what makes him secrete interferon gamma in response to that. We obviously had to cover a very large number of peptides with a finite number of lymphocytes. So we grouped the peptides into pools, but every peptide was represented in at least 2 pools, and positivity in 2 orthogonal pools specifies a unique peptide. So what we showed in this subject was that he had no response to factor IX peptides, but he did have a response to AAV capsid. And at the baseline, he had no positive pools, but at 2 weeks after vector infusion, 3 of the pools came up, and the same 3 pools are still active at week 5, and by week 12, everything is gone, at the point where his LFT is normalized. So we were able to make some other important reagents based on this. So I'm just going to tell you that what we were able to do was high-resolution HLA typing on this subject, and we determined that, among other things, he had a B0702 allele. You can use bioinformatics programs and predict what sequences within the AAV capsid are most likely to bind to the B0702 allele, and when you do that, in his case, what you find is that the predicted best binder is a subsequence of peptide 74, which was one of the peptides that we identified through the interferon gamma ELISpot assays. And moreover, you can now synthesize this B0702 molecule loaded with peptide 74, and now you have a reagent that you can specifically track CD8 T cells with, so you can assay the patient's circulating peripheral blood mononuclear cells for capsid-specific CD8 T cells. And when we did that in this subject, what we were able to show is that you get an expansion of this population of CD8 T cells after the vector goes in, and that expansion of that population of cells tracks very nicely with what's happening to the patient's liver function tests, and that essentially, after the immune system gets rid of all these transduced cells, that population of cells contracts. Now, I'm not going to have time to go through all of this, but I'll just say that, so we investigated enough normal subjects to be able to say that, we don't think this is going to be an isolated phenomenon. We think you're going to see it in other people. It's not just that we were unlucky. We think probably a substantial number of patients in the population are going to have this sort of response. So what can we do? Well, one can imagine a number of potential solutions. We think that trying to engineer out immunodominant epitopes in the capsid is probably going to be pretty hopeless, because there are over 100 MHC class 1 molecules in the human immune system, so I think you're not going to get there that way. I think if there were a reliable way to tolerize the patient to the capsid, I would try to use it, but I don't know of one. And so what we thought about was that we're probably going to use short-term immunosuppression until the capsid peptides can be cleared from the transduced cell. So we've spent a lot of time working out an ideal regimen, and I don't know if we have an ideal regimen, but what we did a series of studies in non-human primates that I'm not going to have time to show you, but the nature of our problem is this: we need to block the CD8 T cell response to capsid without breaking tolerance to factor IX, which depends on another subset of T cells. And so I think we have been able to work out a regimen that doesn't interfere with the induction of the regulatory T cells. And so the next phase of our study, which has been approved by all the regulatory agencies, is to enroll subjects at a dose of about 60% of what subject E got. So that gave him a circulating level of around 10%. These people will presumably get somewhat lower levels, but we still hope they'll be above 1%. But in addition to the vector, they're going to get MMF and rapamycin starting 7 days before vector infusion. We're going to keep that up for 8 weeks. And if at the end of that time they don't have any factor IX expression, we're just going to stop the immunosuppression and go to a higher dose. If they do still have factor IX expression, we're going to continue that for 16 weeks and then taper them off the immunosuppression, see if we manage to rescue some of the transduced cells with this short course of immunosuppression. Now, I think Andrew really wants me to stop right about now, but I just want to show you one other thing. And that is that, we spent all this time building infrastructure. We recruited, we upfitted space in the hospital. We recruited people to manufacture vector, and we recruited regulatory personnel to get clinical gene therapy trials through the regulatory agencies. And we were getting very tired of dealing with this problem about the immune response. And so now we had built all this infrastructure, and the hospital had said, we want you to do, as many genetic diseases you can think of. And so for many years, I had greatly admired the work of my colleague Jean Bennett, who at Penn had been working on AAV injection into the subretinal space for a disease called Leber's congenital amaurosis. And so we went to Jean and said, well, we have all this infrastructure now. Would you consider doing this trial at Children's Hospital? And she said, yeah, I think that would be great. So this is an autosomal recessive disorder that causes early onset retinal degeneration. The symptoms, they're usually diagnosed in infancy because the parents notice that the baby fails to track visually. And there's no treatment for it, and eventually these children just go to blind school and learn Braille. About 10 to 20% of the cases of Leber's are due to a specific mutation in a gene called retinal pigment epithelium 65 kilodalton protein, and there are mouse and dog models of RPE65 deficiency. And what the disease involves essentially is in this layer of retinal pigment epithelial cells, which form the blood retinal barrier. They nourish the photoreceptors, and they complete the visual cycle, which, basically, when light strikes the retina, you convert cisretinal to transretinal. That initiates the action potential that gives you vision, but then you've got to regenerate the cisretinal, and to do that, transretinal moves back from the photoreceptors into the RPE layer, and RPE65 is an isomerase that converts the transretinal back to cisretinal, and you need this for the visual cycle. So what Jean had shown in a paper she published in 2001 was that if she injected an AAV vector into the subretinal space, she could restore sight in these dogs, but you had to do it relatively early in life, because if you waited until the dog was too old, the photoreceptor layer degenerates enough that you can't restore vision. And so we went to Jean in the summer of 2005, initiated this collaboration, did a series of maneuvers to improve the vector and get it ready for use in human subjects, and I don't have time to tell you about those. Did farm tox studies in affected dogs and non-human primates with the new vector, got it through the regulatory apparatus, and I think the hardest part about that was that we did have to convince them to let us do children, but they were willing to do it actually, because this is the first pediatric gene therapy trial for a non-lethal disease. But I think they were willing to do it because they were convinced by the fact that there is the prospect of benefit here. So the young people come in and they undergo a series of testing and they identify the worst eye. And I'm just going to show you one thing because Andrew wants me to leave a little time for questions. And so I want to show you this. This is very compelling evidence that the subretinal injection of this AAV RPE65 restores the ability to perceive light. So this is something that's called the swinging flashlight test. And basically, if you shine light on a seeing eye, the pupil will constrict. And actually, your pupils are yoked together in the brain. So if you shine light into one seeing eye, both pupils constrict. So this swinging flashlight test, what you see here is the pupil diameter. The left eye is blue, the right eye is red. Now here, the blue light is a flash into the left eye in a normal subject, and you see both pupils constrict. Now light is flashed into the right eye, both pupils constrict. Left eye, both. So that's what happens in a normal subject. In these RPE subjects, this is from one of the patients on the trial. So before vector injection, I mean, you can see you can flash light into either eye and nothing happens. I mean, you just get this flat tracing. This was done about 2 months after vector injection. And the right eye was the injected eye. And you can see here, you flash light into the left eye, nothing happens. You flash light into the right eye, and both pupils constrict. The left eye, nothing happens. In fact, the pupils keep dilating because they didn't see anything. And in the right eye, both pupils constrict. So, what you really have here is restoration of the ability of the retina to perceive light. So, that's a really exciting result. And it shows you that when you have a situation where you're using small doses of an optimized vector delivered to an immunoprivileged site, that the results in mice and dogs translate very well into the human subject. So, in this case, we've seen no evidence of immune response. So basically, what we're trying to do in liver-directed gene transfer is ask and answer the question, can we use a pharmacologic approach to create a window of immunoprivilege in the liver that will allow us to achieve long-term expression in this setting as they have done now in the retina. So, okay, I'm just going to stop and say that I have to acknowledge many, many, many collaborators for all the work that I've shown you. So our group at the Children's Hospital, these are the postdocs who developed a lot of the data on immune responses. We did this in collaboration with Gundi Erdl at Penn, at the Wistar Institute. Jean Bennett and Al McGuire were the leaders of the AAV RPE65 trial. And of course, all of the work on the muscle studies and the liver studies for hemophilia was done in collaboration with Mark Kay's group at Stanford, which is a very large group, and these are just some of the people, and a very large group at Avogen, led by these individuals through the years, and James Allen, of course, was part of that group. And then we had a large number of clinical collaborators at a number of institutions for the work in hemophilia, including Art Thompson, who's also here. So I'm going to stop there. I hope there's a few minutes for questions, Andy. Okay, thank you very much for your attention.